Today we are going to discuss the topic, What is Asthma? By Professor Swaminathan Kirahanam. Contact mail ID, profsamiacademy@gmail.com. Next slide. Definition and meaning of asthma. Asthma has been known since antiquity, yet it is a disease that still defies precise definition. The word asthma is of Greek origin and means panting. More than 2,000 years ago, Hippocrates used the word asthma to describe episodic shortness of breath. However, the first detailed clinical description of the asthmatic patient was made by Aratus in the 2nd century. Asthma is now recognized to be a primarily inflammatory condition. Inflammation underlying hyperactivity, an allergic basis can be demonstrated in many adults and a higher percentage of pediatric patients. In others, a variety of trigger factors, infection, irritants, pollution, exercise, exposure to cold air, psychogenic, may be involved. Next slide. Definition and meaning of asthma continues. An expert panel of the National Institutes of Health, the National Asthma Education and Prevention Program, NEP, has provided the following working definition of asthma. Asthma is a chronic inflammatory disorder of the airways in which many cells and cellular elements play a role in acute bronchoconstriction, in particular, mast cells, eosinophils, T lymphocytes, macrophages, neutrophils, and epithelial cells. In a normal person's bronchial tube, the muscle of the bronchi are relaxed and allowing easy airflow and no issue in breathing, but, in the case of asthma patients, the bronchial tube is inflamed and filled with mucus. Also, the muscle of the bronchi is tight and thicker, which impedes airflow and create difficulty in breathing. Next slide. Normal, asthma and asthma attack airway. These illustrations compare a normal airway left, to an asthmatic one middle, and an asthmatic airway during an asthma attack right. Next slide. Key facts about asthma. Asthma affected an estimated 262 million people in 2019 and caused 455,000 deaths by WHO. Asthma is responsible for more than 2 million emergency department visits and more than 500,000 hospitalizations each year. Asthma is the most common chronic disease of childhood, affecting more than one child in 20. In adults, asthma is 35% more common in women than in men. In children, however, the disease affects twice as many boys as girls. Approximately 17% of all adult-onset asthma cases are related to occupational exposures. Currently, 8.4% of persons in the United States have asthma as compared with 4.3% of the population worldwide, and both numbers are on the rise. The average annual asthma prevalence is higher in children, 9.5%, than in adults, 7.7%. Avoiding asthma triggers can also help to reduce asthma symptoms. Most asthma-related deaths occur in low and lower middle-income countries, where underdiagnosis and undertreatment are a challenge. Next slide. Role of Th2 versus Th1 cytokine in allergic asthma. Asthma is caused by an increase in Th2 and a decrease in Th1. Th1 type cytokines tend to produce the pro-inflammatory responses responsible for killing intracellular parasites and for perpetuating autoimmune responses. Interferon gamma is the main Th1 cytokine. Th2 type cytokines mediate the activation and maintenance of the humoral, or antibody-mediated, an immune response against extracellular parasites, bacteria, allergens, and toxins. Th2 cells mediate these functions by producing various cytokines such as IL-4, IL-5, IL-6, IL-9, IL-13, and IL-17E. Next slide. Pathway of asthma. With exposure, the IgE antibodies are produced and attached to mast cells in the lung. Re-exposure to the antigen causes them to bind to the IgE antibody, releasing histamine and other mast cell products. The release of these products causes bronchospasm, mucous membrane swelling, and excessive mucus production. Gas exchange is impaired, causing carbon dioxide to be trapped in the alveoli so that oxygen is unable to enter. The figure identifies the asthmatic pathway from both intrinsic and extrinsic stimulus. Next slide, pathophysiology of asthma. The immediate cause of asthmatic bronchoconstriction is the release of several mediators from IgE-sensitized mast cells and other cells involved in immunologic responses. These mediators include the leukotrienes LTC4 and LTD4. In addition, chemotactic mediators such as LTB4 attract inflammatory cells to the airways. Finally, several cytokines and some enzymes are released, leading to chronic inflammation. Chronic inflammation leads to marked bronchial hyperreactivity to various inhaled substances, including antigens, histamine, muscarinic agonists, and irritants such as sulfur dioxide, SO2, and cold air. This reactivity is partially mediated by vagal reflexes. Next slide, agents and events triggering asthma. 1. Respiratory infection, respiratory syncytial virus, RSV, rhinovirus, influenza, parainfluenza, mycoplasma pneumonia. 2. Allergens, airborne pollens, grass, trees, weeds, house dust mite, animal dander, cockroaches, fungal spores. 3. Environment, cold air, fog, ozone, sulfur dioxide, nitrogen dioxide, tobacco smoke, wood smoke. 4. Emotions, anxiety, stress, laughter. 5. Exercise, particularly in a cold, dry climate. 6. Drugs, preservatives, aspirin, cyclooxygenase inhibitors like N-S-A-I-D, known as non-steroidal anti-inflammatory drugs, sulfites, benzalkonium chloride, and beta blockers. 7. Occupational stimuli, bakers, flour dust, farmers, hay mold, spice and enzyme workers, printers, Arabic gum, chemical workers, azo dyes, anthraquinone, ethylenediamine, toluene dissocianates, polyvinyl chloride, plastics, rubber, and woodworkers, formaldehyde, western cedar, dimethylethanolamin, anhydrides. Next slide, types of asthma. 1. Extrinsic asthma, other name known as atopic asthma or allergic asthma. This is the most common type of asthma and usually begins in childhood or in early adult life. Most patients have personal and/or family histories. Hypersensitivity to various extrinsic antigenic substances, house dust, pollens, animal danders, molds etc. There is an increased level of IgE in the serum, IgE-mediated type I hypersensitivity reaction, which includes an acute immediate response and a late phase reaction, acute immediate response, initiated by IgE, sensitized mast cells and release, mediators like histamine, leukotrienes, prostaglandins, platelet activating factor and chemotactic factors for eosinophils and neutrophils. The net effects of these mediators are bronchoconstriction, edema, mucus hypersecretion and accumulation of eosinophils and neutrophils. Late phase reaction, caused by excessive mobilization of blood leukocytes that include basophils besides eosinophils and neutrophils. In addition, inflammatory injury is caused by neutrophils and eosinophils. Next slide, types of asthma, continue. 2. Intrinsic asthma, other name, idiosyncratic asthma or non-atopic asthma. This type of asthma develops later in adult life with negative personal or family history of allergy, negative skin test and normal serum levels of IgE and D. Most of these patients develop a typical symptom complex after an upper respiratory tract infection by viruses. Associated nasal polypi and chronic bronchitis are commonly present. There are no recognizable allergens, but about 10% of patients become hypersensitive to drugs, most notably to small doses of aspirin, aspirin-sensitive asthma. 3. Mixed type. Many patients do not clearly fit into either of the two categories and have mixed features in both. Those patients who develop asthma in early life have a strong allergic component, while those who develop the disease late tend to be non-allergic. Either type of asthma can be precipitated by cold, exercise and emotional stress. Next slide. Extrinsic allergic asthma. Clinical features. It most commonly affected young patients, children or teenagers. Family history is usually positive. Attacks related to specific antigens like pollens, foods, drugs, dusts, danders. Skin tests are usually positive. History of eczema in childhood. Allergic shiner may be present. Favorable response to hypersensitization. IgE associated. Attacks acute but usually self-limiting. Prognosis favorable. A condition often outgrown but may become chronic. Death is rare. Next slide. Type 2. Intrinsic asthma. Other name, idiosyncratic or non-atopic asthma. Clinical features. It most commonly affected adult patients, age 35 or over. Family history usually negative. Attacks related to infections, exercise, other stimuli. Skin tests usually negative. No history of eczema in childhood. Unfavorable response to hypersensitization. Not IgE associated. Attacks more fulminant. Prognosis poorer. The condition may become chronic. Death may occur in severe cases. Next slide. Contrasting features of the two major types of asthma. The feature contrasting with extrinsic asthma, intrinsic asthma. 1. Age at onset, in childhood in extrinsic asthma, in adult in intrinsic asthma. 2. Personal, family history, commonly present in extrinsic asthma, absent in intrinsic asthma. 3. Preceding allergic illness, atopy, present, example, rhinitis, urticaria, eczema, in extrinsic asthma, absent in intrinsic asthma. 4. Allergens present, dust, pollens, danders etc. None in intrinsic asthma. 5. Drug hypersensitivity, none, in extrinsic asthma, present, usually to aspirin, in intrinsic asthma. 6. Serum IgE level elevated, in extrinsic asthma, normal in intrinsic asthma. 7. Associated chronic bronchitis, nasal polyps, absent in extrinsic asthma, present in intrinsic asthma. 8. Emphysema, unusual in extrinsic asthma, common in intrinsic asthma. Next slide. Clinical presentation of ambulatory asthma. Ambulatory care or outpatient care is medical care provided on an outpatient basis, including diagnosis, observation, consultation, treatment, and intervention. Ambulatory patient is. This means the patient is able to walk around. This slide discussed the clinical presentation of ambulatory asthma, symptoms, chest tightness, episodes of dyspnea, coughing, particularly at night, wheezing, or a whistling sound when breathing. These often occur in association with exercise, and allergens. Signs: expiratory wheezing on auscultation, dry hacking cough, signs of atopy, allergic rhinitis and or eczema, may occur at laboratory. Spirometry demonstrates obstruction, forced expiratory volume, FEV1 divided by forced vital capacity FVC is less than 80%, with reversibility following inhaled beta-2 agonist administration, at least a 12% improvement in forced expiratory volume, FEV1. Other diagnostic tests, fall in forced expiratory volume FEV1 of at least 20% following 6 minutes of near maximal exercise. Elevated eosinophil count and LGE concentration in blood. Elevated fractional exhaled nitric oxide greater than 12 ppb. Positive methacholine challenge, PC20, forced expiratory volume, FEV1 less than 12.5 mg in milliliters. Next slide. Clinical presentation of severe acute asthma. Symptoms: the patient is anxious and in acute distress and complains of severe dyspnea, shortness of breath, chest tightness, or burning. The patient is only able to say a few words with each breath. Symptoms are unresponsive to usual measures. Beta-2 agonist administration. Signs. Signs include expiratory and inspiratory wheezing on auscultation. Breath sounds may be diminished with very severe obstruction, dry hacking cough, tachypnea, tachycardia, pale or cyanotic skin, hyperinflated chest with intercostal and supraclavicular retractions, hypoxic seizures if very severe, normal or slightly elevated temperature. Laboratory test, peak expiratory flow, P-E-F, and/or forced exhalation volume in 1 second F-E, V1 is less than 50%, decreased arterial oxygen, PO2, and O2 saturation by pulse oximetry, less than 90% on room air, decreased arterial or capillary CO2. Other diagnostic tests, blood gases to assess metabolic acidosis, lactic acidosis, in severe obstruction. Complete blood count if there are signs of infection, fever and purulent sputum. Beta-2 agonist and corticosteroids can lower serum potassium and magnesium and increase glucose. Chest radiograph if signs of consolidation on auscultation. Next slide, risk factors and complications of asthma. First, risk factor. Having a blood relative with asthma, such as a parent or sibling. Having another allergic condition, such as atopic dermatitis A which causes red, itchy skin A or hay fever A which causes a runny nose, congestion and itchy eyes. Being overweight, being a smoker. Exposure to passive smoking. Exposure to exhaust fumes or other types of pollution. Exposure to occupational triggers, such as chemicals used in farming, hairdressing and manufacturing. Second, complications, signs and symptoms that interfere with sleep, work and other activities, sick days from work or school during asthma flare-ups, a permanent narrowing of the tubes that carry air to and from your lungs, bronchial tubes, affects how well you can breathe, emergency room visits and hospitalizations for severe asthma attacks, side effects from long-term use of some medications used to stabilize severe asthma. Next slide, prevention of asthma attacks. Pay attention to increasing quick relief inhaler use. Asthma isn't under control? See the doctor about adjusting the treatment. Take your medication as prescribed. Identify and avoid asthma triggers. Several outdoor and indoor allergens and irritants trigger asthma, for example, dust, pets, pollen, mold, cold air and air pollution. Monitor breathing. Recognize warning signs of an impending attack, such as slight coughing, wheezing or shortness of breath. Follow asthma action plan. Asthma is an ongoing condition that needs regular monitoring and treatment. Get vaccinated for influenza and pneumonia. Vaccinations can prevent flu and pneumonia from triggering asthma. Identify and treat attacks as early as possible to get medical help. Thank you for your attention. Further information, kindly contact profsamiacademy@gmail.com. Disclaimer: this channel does not promote or encourage any illegal activities, and all contents provided by this channel are meant for educational purposes only. Any copyrighted material on these slides is included as fair use for educational purposes only. It will be removed at the request of copyright owners.